Hello, my name is Martin Offringa. I'm a staff pediatrician in the Hospital for Sick Children and a senior scientist at the Sick Kids Research Institute at the University of Toronto in Canada. Today, I will speak about a recently published study entitled Core Outcome Set for Children with Neurological Impairment and Tube Feeding. This work was conducted at the Enrich Lab. Children with neurological impairment have conditions of the brain and neuromuscular system that are associated with functional limitations like cerebral palsy and feeding difficulties. In some children, this leads to negative feeding experience for both child and their family. We often see episodes of choking, vomiting, aspiration, pneumonia, and growth failure. This is why gastrostomy and gastrojejunostomy tubes, also called G and GJ tubes, are placed. Now, although these tubes have been shown to improve nutritional outcomes, there is still uncertainty regarding their impact on survival, respiratory health, feeding times, caregiver burden, child and primary caregiver quality of life, and healthcare utilization. The literature to date is inconsistent. Different researchers are measuring different things as outcomes, and even when measuring the same outcome, they may measure it in a different way. This is called heterogeneity in outcome terminology, definition, and measurement among the current empirical studies in this field. This heterogeneity contributes to the current uncertainty about G-tube feeding's efficacy. We need additional research into these tubes' outcomes. But this time with a consistent approach to the selection, definition, and reporting of outcomes. A solution would be a core outcome set, commonly called COS, for children with neurological impairment and feeding tubes. A core outcome set is an agreed standardized set of outcomes that should be measured and reported as a minimum in all clinical trials in specific areas of healthcare. Consistent use of a COS in research will foster between study comparisons and meta-analyses. However, a core outcome set does not restrict trialists to measure other additional outcomes. The objective of our study was to develop a core outcome set for use in prospective studies of children with neurological impairment and feeding tubes. The first step we took was doing a systematic review to generate a list of categorized candidate outcomes for inclusion in the eventual core outcome set. In 2016, we published this review in another journal and identified all reported outcomes in clinical studies of children with neurological impairment and feeding tubes. In 104 studies, we found 120 unique outcomes with substantial heterogeneity in their definition, measurement, and reporting. Most outcomes were reported in just one study only. These findings demonstrated the need for a core outcome set. We assigned the 120 outcomes to 5 core outcome areas: growth and development, life impact, resource use, death, and pathophysiological manifestations of the disease. Most outcomes were provider-measured pathophysiological manifestations, as seen in this table from the systematic review. The results generated by this review were used as the basis for our next step. In an online survey, we prioritized those outcomes we would discuss at an in-person consensus meeting using a Delphi technique. We went from 120 candidate outcomes to 88 that were considered important in the survey. The Delphi further reduced the number of candidate outcomes to 49. To reach consensus on the minimal set of outcomes that will be relevant to all stakeholders, an in-person consensus meeting was held at the Hospital for Sick Children. Consensus meeting participants included clinicians, clinical epidemiologists, trialists, and health service researchers. This group discussed and voted on a final core outcome set consisting of 12 outcomes. We then validated this list of 12 outcomes with a group of 12 primary caregivers, in fact parents of children with neurological impairment and feeding tubes. We asked the parents what outcomes are most important from their perspective. No changes were recommended or new outcomes proposed. Here we see the final core outcome set. The COS is divided in 5 core areas. Under growth and development is the core outcome nutrition, growth and developmental state. In the life impact core area are the outcomes child pain, child physical health state, child's quality of life, duration and ease of food and medicine administration, and caregiver quality of life. The core area resource use contains the outcomes days spent admitted to hospital and intensive care per year and frequency of doctor or clinic and emergency room visits per year. Death falls under the death core area. The 5th core area, pathophysiological manifestations, includes the outcomes tube malformation, retching vomiting, and aspiration pneumonia. We recommend to measure all these 12 outcomes in all new studies in this field. As I mentioned before, other outcomes can be measured in the individual studies as well. But this is the core outcome set that all studies should measure. Currently, work is being done to agree on harmonized definitions on how to best measure and how to report these outcomes. When implemented, this set will be helpful to researchers in improving the design, quality, and utility of their future clinical research studies. This then will eventually enhance the feasibility of knowledge synthesis in meta-analysis. Thank you for watching.